It's a great honor to chairing this session, and we will have several speakers on the topic of the use of opioids in chronic pain. For those who do not know me, my name is Bart Morlion. I work at the Catholic University of Leuven in Belgium, and I'm also the president-elect of the European Pain Federation, EFIC. And please allow me a few minutes to introduce the reasons why we choose this topic on our schedule. So setting the scene of this hot topic. First of all, we will deal with opioids in chronic pain. So we should be aware that chronic pain, the paradigm clearly shifted over the last decennia. And chronic pain has to be considered as a biopsychosocial phenomenon. And the thing we always introduce as a concept to our patient is you never can deal with biopsychosocial phenomenon if you only deal with medical technical approaches. And that's the reason we talk about the three-pillar system: medical, technical, psychological, social approaches. And of course, medical technical can include, in some indications, interventional pain management, very importantly, physical approaches, exercise, and so on, but also pharmacological. So to be clear, this is the framework we will be moving in this afternoon, and now we will focus on pharmacological treatment as part of a multimodal strategy. So within this multimodal strategy, pharmacotherapy has a corner place. But remember, there are many other approaches, and the best chances to get success in your patients with chronic pain is to deal with all angles in the approach and a comprehensive approach. Opioids have been around since many, many centuries, and you know all these pictures, and I'm not sure if I have copyrights to show them to you because this session is webcasted. But the thing is that since many thousands of years, the forces and the properties of opioids have been known to mankind. Even until after the First World War, heroin, morphine was available in a very, very liberal way, like coughing syrups and so on and so on. What happened over the last 35 years, and maybe I'm not correct in stating 35, maybe it's 38, and it's going on much longer, but opioids have become standard of care in acute pain, anesthesia, postoperative care, and cancer pain management. And there have been huge efforts, especially from part of the WHO and initiatives by many large scientific organizations to destigmatize opioids. Because there was people 30, 40 years ago, many colleagues were very reluctant to prescribe opioids to their patients, or they were hampered by strict regulations in their respective countries. And there has been a very broad discussion, and ethical arguments were brought to shift from dying cancer pain patients to all cancer pain patients. And the step further was then to non-cancer patients. There have been massive WHO campaigning efforts to improve accessibility to opioids throughout the world, but still nowadays there are regions where there clearly is a problem with accessibility to opioids. And we witnessed an increasing use in chronic non-malignant pain. And then, to prove that I make very updated lectures, this was published June 15, 2015, the cover of Time. They're the most powerful painkillers ever invented, and they're creating the worst addiction crisis in America has ever seen. And most of you are well aware what's happening over the last 5 to 10 years, because indeed one of the pivotal papers coming out in New England Journal of Medicine, but also in other major medical journals, stated that there are more death cases in the United States because of prescription drugs, opioids in this case, than cocaine and heroin together. And this brought up a complete movement. And before going into details and in looking what's happening, We should be aware that we have the European Pain Federation meeting today here in Vienna and over the next days. And I want just to remember that there are differences what happens in the United States and in Europe. Just to give you some example, because I could have shown you BMI, body mass indexes. There also we have clear differences between many European countries and the United States. But just to give you some example, firearm-related homicide rates by selected countries 2012, officially reported numbers. And there you see that the United States also behave different than most of the European countries. If we look at morphine equivalent per day, the so-called meds, and I'll come back to that one, in milligrams per person, and these data are not the most recent to my, I didn't get any more recent than these ones, but there you clearly see that there was a huge increase in the MEDs in the United States, up to 800 milligrams a day. And in the blue line, you see the range where the European data. So a complete different situation between the United States and European countries. So what's happening? The question is the pendulum swinging over? During many decades, there was an action of, we started with stigmatization of opioids, then huge campaigning about destigmatization. And now maybe we went into a phase of over-destigmatization, because if you go into details, what's happening or what happens in the United States, as an observer, a clinical observer from Europe, I must state that yes, there is a non-critical prescribing of these drugs without any good patient selection and especially without re-evaluation. And some people talk about real pill mills where people just get their prescriptions of these very strong drugs. And this bears a risk, because this bears the risk of stigmatization again. Medical legal directives, this is happening already in many states of the United States. There are calls for limiting the MEDs and so on and so on. And that's the reason we want to put this issue on the agenda of this refresher course. We do not want to start a debate. We will have a very good overview of the pharmacology, of the evidence, we give examples how the practical prescribing can be done, and we will end with how can you get with the exit strategies. There have been many guidelines for long-term opioid therapy in many different countries. But in some of these issues and parts of the guidelines, there is consensus. However, there are many differences and debates about urine drug testing, toxicology, and so on, about the discussion on MEDs. And for this reason, the European Pain Federation decided to put up a task force, and hopefully by end of this year, we will be able to publish the results and have recommendations, a kind of guidance, because we feel that a lot of colleagues get unsure by all these negative signals from the United States. So, to state an old saying, the saying is throw the baby out with the bathwater. So there is really the risk of swinging to stigmatization again. And this risk has also, therefore we risk that possible valuable therapy might be denied to chronic pain patients because of medical legal concerns. So my call at the start and a short introduction to the next speaker is, let's not throw out the baby with the bathwater. It's my pleasure to hand over now for an overview on the pharmacology of opioids to Professor Tony Dickinson. He is professor in neuropharmacology at the University College of London. And I will be very brief in the bios, because you know you have an app, and in the app you click on speakers and you will find immediately all the details of our biographies. That's a mean of using modern technologies. After that, we will have a talk on the level of evidence, indications, limitations. Then I will come back with some practical prescribing, and we'll have a short coffee break. prevention and management of aberrant drug behavior, and then exit strategies. I wish you a good refresher course this afternoon in Vienna.